and the transportation infrastructure industry, apparel, fashion, the food, beverage. Just I saw yesterday, like a John Cool in the USA, one of the biggest apparel is bankrupt. And only pharmaceutical company may be increasing capitalization. So the COVID-19 pandemic is also an economic crisis. But also, according to Google, because of a very strict movement, the social distancing measures, like this is a retail recreation mobility change minus, and it is grocery and pharmaceutical pharmacy type of movement, except Mongolia, every country it decreased. This is the people go to the park. This is also reducing, except Mongolia. This is at the transition station. And even Mongolia decreased. And this is workplace. So people don't go to the office, don't go to the transit station, don't go to the park and the grocery, retail recreation because of very strong government measures. So people more stay in their residential area. So it means COVID-19 pandemic is a social crisis, including children cannot go to the school. So the COVID-19 pandemic has many aspects. I don't say this is an indirect or secondary effect, but rather describe COVID-19 is a social crisis. And there are 23 non-pharmaceutical public health interventions currently implemented across the world. This is also McKinsey, very good summarize. I just using this one. Like for health, very famous, like a time-limited quarantine and infect patient. This is impact is basically epidemic area and the health area. And the other thing, like a protection of health workers and using PPE, personal protection equipment and protocols, also influencing very much in the health area. And the systematic testing and the contact tracing is basically focusing health, public health crisis. So how about, and also movement and restriction very much influencing public health impact, economic impact, social impact. So how about the WASH intervention? Basically, this is the personal behavior change and focusing personal home hygiene, hand washing, and don't contact to the public surface, public famous surfaces of visit. This is, of course, impact to public health intervention. However, more importantly, the WASH intervention impact social crisis. I just try to explain why. This is a recent finding. This is just recently published in the JAMA, it's American journal. That we know the cough created a droplet, and the droplet including many COVID-19 virus called SARS coronavirus 2. And we knew that maybe travel 1 meter, 2 meter. But this is the only cough situation, and the cough creates some sort of 1,000 of droplet, but the sneeze, the more than create 50,000 droplet, and even travel more. Now, according to this researcher, the droplet created by sneeze can travel even 7 to 8 meters if the closed room setting. So we now know much more droplet travel within a very limited environment. But also Japanese researcher also recently, the risk is not just limited to sneezing or coughing. This is normal conversation if people speak each other to face. And the many droplets are taking in the air and may contact each other. And if they are who are talking, and many droplet, it's is transmitted and in a normal environment. And this is also you know very well. And coronavirus, SARS coronavirus 2 virus can stay in a copper around 4 hours, on the cardboard surface 24 hours, and the stainless steel 48 hours, and plastic 72 hours. So it means coronavirus exists even invisible situation is for a long period. That is why people is not recommended to touch unnecessarily in surface like particular plastic and stainless steel. This recommendation, this behavior change required a huge social implication. And the particularly wash intervention is very important because some countries start easing school closure measure. Particularly, this is important for a primary school student. And a school student, if they're back from the quarantine or lockdown situation, of course, school facility must provide and also promote a regular and hand washing station. And not only soap and safe water, but also age-appropriate wash stations are required. This is everyone, I think, you are working very hard. But also, the people touch those washing stations, like a tap or pump, and we need to clean and disinfect these areas, particularly water sanitation facility, by using several disinfectants like sodium hypochlorite or alcohol. Because children may frequently touch those areas. But also, you can see the video showing droplet easily travel in a very closed setting. The majority of the school, particularly primary school in this region, is very crowded and less ventilation situation. So we really need to increase airflow and the ventilation or ventilator room when climate are low, like open windows. In some condition, maybe air condition with high efficiency filter is installed. This is also recommended. But also ensure trash is removed daily and disposed safely. So wash, particular intervention is very important. Children go back to school, and that is why social impact is very important for by wash intervention. And also, the people behavior currently still is not 100% optimal, like using COVID-19 public behavior monitor by UK government. This is a British-based market research, and interview more than 27,000 people in 26 countries, including several EAP countries, and collaborating with Imperial College London. So that is why data is available by hashtag at the YouGov. And this is a % people each country who say improving personal hygiene, wash hands frequently is very important. So it's Asia Pacific regions, majority people feeling wash hand or personal hygiene is important and practice 80%. However, still 10% gap exists in those in EAP region. So 10% people may not think hand washing personal hygiene is important. So it means we need to reach out more than 10% people in this region. But the other aspect, this is a question related what is important for you refrain from touching object in public. Like Indonesia is not so high, and only 55% people say I may not care about touching public spaces, public object. And majority countries still 30% gap. So people's behavior knowledge may exist, but still not yet fulfilled, optimally implemented. So how we can see how people's engagement with people important to increase personal protection measure, particularly for hand washing, and not unnecessarily touching public object in public. However, the mathematical modeling very clearly showing if social distance measure and reducing shopping means people don't travel in a very crowded area, and reducing infection rate by personal hygiene, particularly hand washing and respiratory etiquette, how this COVID-19 infection can be reduced. And because people don't travel to the area, the very crowded area, and also people practice hand washing, and people keeping social distancing, so the infection rate is reducing, and as a result, maybe first wave of COVID-19 pandemic can be controlled in this setting. And Thailand is currently reducing their infection rate, and so Thailand start easing their social distancing measure. So, and I think Vietnam is also following. The other country in this region also start kind of reducing social distancing measures gradually. However, the same mathematical modeling may say, if people reducing restriction of travel, meaning going to travel for shopping or other area, and the social distancing factor is reducing by close interaction with people by like a face-to-face talk, and also not hand washing properly. What is happening? Like after a control measure implemented, and also the government decided reducing those social distance measures, because people travel and also people don't practice hygiene behavior. So second wave can be much bigger. This is what mathematical modeling say currently. And those transmission dynamics, as already explained, timing extent of control measures very influenced, but also population immunity, so-called herd immunity, may affect. However, according to European and other areas studies say, the Denmark only 1.9%, Netherlands 3.2%, I think this is the highest. Scotland in UK 1% among healthy blood donors. There are other studies showing, but maybe healthy blood donor may tell us how about population immunity. So even in Europe setting, only 3% maximum the population have immunity. So, and also we don't know this immunity means how to protect how long. And it means duration of host immunity to SARS coronavirus too. This is also very much influence the transition dynamic in the future. And we don't know cross immunity between current SARS coronavirus too and other human coronavirus. But actually 40% of normal flu among the children is come from other human coronavirus. Some researchers initially said, why children's infection rate is so low? Maybe there are some cross immunity between the SARS coronavirus to other human coronavirus to expose children, but we don't know yet. And there are a possibility of potential seasonality. Temperature, humidity, and UV ultraviolet may affect survival rate in coronavirus. However, we don't know yet. But some researchers start thinking that most likely the seasonality can be happen. And also virus itself is a very interesting feature, including incubation period is very long. And also asymptomatic infection rate, approximately 20% to 25%, meaning we don't know who are infected. This is a very difficult to control this type of pandemic. And also virus shedding may peak before symptoms occur. So means that many, 1 in 5 people having no symptom, but also spreading virus. And the one virus infected person may infect other 2 or 3. So those factors may tell us this first wave is not only our pandemic. So there are three possible scenarios made by a CIDRAP group. This is one of the research university group in the USA. Scenario one is the peaks and the valleys and up and down, may continue to January, mid of January 2022. So my country hosts Olympic in Tokyo, however, may not happen again 2021, even the postpone. The second scenario, the first wave in this summer, like you see the several one or two wave in front, but the biggest outbreak may happen fall and winter in 2022 because of this seasonality and the herd immunity is not so high. The third scenario, and the slow and burn, maybe the first, the second wave is a peak and then gradually decreasing, but the continue to small scale one up to January 2022 or 2023. So all three scenarios need to tightening and easing social distance measure as periodically. So even those three scenarios needs additional intervention in coming years. So this is a possible scenario, but still this is one researcher, several researchers have another scenario, but this is the one with the most recent one. I guess in this region, majority country, maybe scenario one. So the same peak, but not high, may come frequently in 2021, 2022. And but this is lessons from particularly for Singapore. And Singapore is first wave controlled very well, but second wave, third wave affected dormitory and the foreign workers. This is also a result of social structures. So all pandemic scenario may need context specific scenarios. I cannot generalize all scenarios, but this definitely the most possible scenario in this region is scenario one. And the summary, my message very clear. Investing in WASH is not just water sanitation improvement, but contribute to protect health workforce and the system. And also particularly important mitigating social impact. And we may need to, of course, new normal, that as WHO say, but WASH intervention can be contribute to creating a new but better normal because the social impact may be reduced significantly by WASH intervention. But this intervention, this presentation is my view, is not representing official position in SBAPRO. Thank you very much.
Thank you, Dr. Chris. Thank you very much for a very comprehensive presentation. Colleagues, if you have any questions, you may please write in the chat box, or anybody who wants to speak, please you can on your mic and put your question to Dr. Chris. We may just have 1 minute for that.
No.
Yes, Mukhtar.
Hello.
Go ahead.
This is Mukhtar. Chris, thank you very much. As usual, your presentations are amazing, giving us very valuable information and analysis and looking at all these scenarios and so on. I wonder how much collaboration is there within the Asia Pacific to look at all these scenarios.
Yeah, I can hear you.
Particularly in scenario one
Yes.
for 20
I have my work right here.
up to 2021, so that this advice can sink into the policymakers, particularly looking at the ASEAN structure or other structures that exist, the SARC. How does this message get across to the government? Because this is scientific analysis. That's my question.
Thank you very much. Of course, this scenario is not only yet in a scientific table, discussion table. And because of not so many data available, particularly effective reproduction number calculation is not available in this region. So very difficult to predict. However, the ASEAN or SAARC, particularly I think ASEAN member states has a very much aware of possibility of second wave because their testing capacity is not high. The two interventions possible, either strong social distancing measure, stop all travel and all activity, definitely can stop COVID-19 spread because of China, Wuhan show cases, but at least 40 days, 60 days needed. But this huge economic implication, any of a country cannot afford this option. The second option, test all as many as possible people tested, like South Korea, Republic Korea did it. But also this is a capacity of test and also a huge cost implication. So they need to mix the measure. So that's why it's not 100% possible to contain. So I think politicians are very aware and think how they collaborate, particularly neighboring countries. So regional collaboration may be enhancing after COVID-19 first wave one. So I really expect that some Korean can have a jointly say how we can support those government efforts. So maybe policy, majority policymaker may be aware. This is my speculation.
Thank you, Mukhtar, for the great question in terms of how do we collaborate with the government and how do we get the messages across the government in terms of the social and the economic impact of COVID-19. And thank you, Dr. Chris, for clarifying and particularly for the Asia Pacific region on the ASEAN, how the governments are taking up the measures to contain and to reduce the infections and the cases. With this, maybe I invite now Everest, our regional advisor, was to quickly give us a brief overview of the regional context from a WASH perspective, and then we move forward. Over to you, Eva.
Great, thank you very much, Anu. I just put a question there to Dr. Chris. If you can have a time to respond, that might be very, very good for us. The question is more related to a lot of body of evidence on the medical body showing that the COVID-19 is more a blood disease, and and then there's a lot of effort basically to find common drug to solve that. My question to Chris is, are we coming very soon to normal? Maybe you can respond to after my presentation. So I will share you a few points, and this is based on some of the presentation done by WHO, UNICEF earlier on some of the evidence related to our work in terms of WASH. So as Dr. Chris say, it's very important to take into account water sanitation and hygiene in terms of COVID-19, particularly in this region where we are facing many hazards as well, water scarcity. We have a lot of major cyclone, many other hazards hitting the region as well. So it's very important to see how what are the evidence, what are the information that you can base our intervention on. And based on the many information and many research and many review, WHO and UNICEF published some of the key material related to COVID-19 and also how it impacts water and sanitation sector. Clearly, what we have seen now, unless there's any publication yesterday I've not seen, there's no evidence that COVID-19 virus is found in drinking water, and also there's no evidence that other surrogate like substitute of human coronavirus is present in sulfur on groundwater. So the fact that this envelope has a coron and also some lipid component make it more weaker, basically more fragile to be inactivated and then be killed very quickly. We have seen in some of the studies that have been done, in US, in UK, that few patients, do have some, the part of virus in there too, which is, but it's only actually one study showing that very clearly that you have seen. And based on what's happening, in China or in Italy, and US, we also have, some of the patients having COVID-19 have a diarrhea as well, which is one of the signal, one of the symptoms that have been recorded. Now, some of the research that have been done before, like I say, the surrogate is like a substitute for human coronaviruses. Yeah, we realized that some of the studies show that even in dechlorinated tap water at a 20-degree temperature for 2 days, they don't survive. The coronavirus, the surrogate don't survive. And then we can see that in various surface, like Dr. Chris has presented earlier on, between 2 hours and 9 days, we say between, I think, like 9 days, most of them will disappear. This is the study shown by Journal of Hospital Infection in 2020. So, and you can see that clearly for the water supply, whether dechlorinated or sewage water, but they do remain for a certain period of time. In the baby feces is more or less 3 hours. And then we can realize also for the human, it can stay till at a 20 degree for one day as well. So those parameters are very important for us as we might be designing water supply system, designing a sewage system, or designing wastewater treatment system, or managing a fecal sludge. We need to take into account those various or those downtime for a very removal, so that we can basically plan for the intervention. So one of the things that has been shown very, very clearly also in many areas, like the heat, the impact of the heat, the high and low pH, and also the sunlight and common defector playing a huge role in a viral killing, in dying of, it's facilitated viral to be killed very quickly. So it's one that you see. I recall that there's a study done in China between January and February 2020 for 429 cities, showing the whole potency of the virus using the heat, the pH, and also the UV, and saying how the potency reduced over time as well is something that we need to take into consideration. And then we can, like Dr. Chris say, well, that on the surface, it can be very inactivated in 1 minute using 7% ethanol, degree ethanol, or sodium hypochlorite. To the comparison for other viruses like adenoviruses, which is not in envelope, those viruses which is not in envelope can survive more than the one that you have now, like our coronavirus that you have now. So it's very important to take into account. It's not so dramatic, but I think there's a way to kill it very quickly. These kind of viruses. So some of the guidelines that have been developed that we need to use also when we are considering doing an intervention. The civil managed water supply, for that you have guidelines for drinking water, wastewater planning, and planning is very important. Also, water treatment performance guidance that have been developed, or the essential environmental health standard that will be developed by WHO for the healthcare facility. So some of the key considerations need to be taken into account: use of water safety approach, protection from the source to the consumer. We need also to make sure that we maintain the residual chlorine in water treatment system. And also for the point of use, we need to make sure that the water be safe, and then there's a chlorination in, and make sure that that we can kill all the germs. So we thought about the framework in this region that can basically help, and how we advance, we support those interventions related to COVID-19 in the region, based on the 3 main pillars that have been developed globally, and then on which we are working on. I think it's very important to come up with some of the some of the strategy that will help basically move forward and also support the country. The question I used to ask, what is totally different responding to COVID-19 than what we are doing now? I think one of the key pillars that are coming predominantly in a WASH that UNICEF WASH is doing is the intensification of hygiene promotion to prevent human-to-human transmission, and also our work on WASH infection and prevention control, that coming up very strongly to support health sector as well. And then the last pillar is how we continue doing our business, putting in place some of the safeguard to support WASH workers, WASH practitioner, WASH sector stakeholder to continue doing their work. I think those are the three main pillars that we basically use to work in the week, in the short term, in mid-term, and long term as COVID-19 is progressing. So, and then we need to take care of some of the areas that we are not used to do work, the quarantine center that are coming very quickly, the detention center, where we see those kind of challenges arising. And also we might see as well some of the new areas that we are not working before, like police center, where there's some detention. So there's a new area of work that has been created, which an opportunity on which we can work on very quickly, as well as some of the innovation that have been developed that we need to take into account to advance the agenda. New partnership developed, or also a new area of work. Just want to point off some of the key challenges related to those interventions is the supply of the goods and services, right? There's a huge demand of water and sanitation supply now that even UNICEF, who is a champion of providing the supply, may have a lot of delay to responding to all those demands in the country. And then we need to identify, new area of supply the whole sector as well. So some of the technical guidance that have been developed, I think, which are very important, the joint WHO, UNICEF guidelines, UNICEF programming guidelines for the country office, I think is very important. And then there's a lot of work be done in terms of assessment, washing school assessment, vis-a-vis of the upcoming opening of the school, washing healthcare facility assessment as well. And then, there's a big work have been done on the impact of COVID-19 on water and sanitation services, which is one of the huge areas that we can see on 4 different areas. One is how it impacts the user, the consumer. The second one is the service provider. I think, the small utility, the big one, how the COVID-19 impact that. And then also the government, how it impacts the whole policy, the discussion we have on the policy formulation. Those 3 are very important, as well as the financier, which is one of the key areas that is very important. How the repayment of the loan that has been borrowed is still, the repayment is going on based on if the user are not paying the tariff, are not paying the water services. What are the mechanisms that put in place? I think it's a huge bunch of work that we'll be doing in the region in the coming months, basically to better understand how COVID-19 is impacting water and sanitation services. I was in the call with our colleague in Fiji this morning, very interesting to see how they are working on gender, disability, and also in terms of COVID-19 related to WASH, which is something that we should learn basically and fuse our discussion at the regional level and also with other partners. So thank you very much, Anu, for being active for organizing this as well. And I just want to share also some additional technical brief, particularly the one on water and sanitation, hygiene, and waste management for COVID-19, which is one of the important guidance that help basically understand and manage whether it's COVID-19 on surface or through the transmission in the hotel, in many areas, on waste management. I think it's how do we handle that is very important as well, that we need to basically take into account as we support the intervention of the country. Over.
Thank you, Everest. Thank you very much for your presentation on some of the WASH evidence, but also some of the technical guidance that UNICEF and WHO have been producing over the past few months. And maybe there may be some issues at the country level in terms of contextualizing this guidance to their context. So we would now love to hear from some of the country experiences in terms of how they have been able to use this guidance, how the, how the global level guidance have helped them to reach the governments and advocate with them in reducing the infections. So maybe we now hear more from the country and the regional perspective. So I would now like to invite Samuel Ong, who is the manager for international services for the Singapore Red Cross, but also have the experience of working in different other countries in the region. And Fauzia, who is also the manager for Red Cross, to please share your experiences with us. Over to you, Samuel and Fauzia.
Hi, thank you so much, Anu. So just to introduce myself, I'm Fauzia. I'm from the Singapore Red Cross as the manager of the international services.
We cannot hear. We cannot hear, please.
Hello? Can you hear me?
It's fine now. Thank
Okay, great. So hi, just to introduce myself, I'm Fauzia from the Singapore Red Cross. I'm a manager with the international services. I'm currently based in Singapore, and I'll just be sharing a bit about our response to COVID-19 in the Asia Pacific region. So firstly, our very first step once we heard all about this news about COVID-19 coming in the region was to plan our business continuity. And so we took a step-by-step approach as part of our pandemic preparedness program. First with business continuity planning so that we can maintain essential services and so that we can begin new activities related to COVID-19. So one of the very, very first things that we had to take into consideration was how we could protect our staff and volunteers who are essential to our services and to the new activities that we will be taking on. In order to protect them, we had to take stock of our resources because we have a few different sites that we work out of. We have the main headquarters, we have our campsite, we have our Red Cross home for the disabled. We have our blood donation centers. We first had to consolidate all our resources into a central stockpile. So existing masks, hand sanitizers, disposable gloves were now all centrally managed. And we had to take count of existing stocks and plan for future demand. So we planned for a 6-month duration, and also considering that we were encountering supply chain problems. And we also had to take into consideration the requests from various departments, from our blood donation recruitment department, from our community resilience department, and from our very own international services department, as we were sending one of our colleagues to China, and that is Samuel, who is currently still over there in Beijing. The other thing that we had to do is that we had to communicate to staff what will be happening over the next few months to prepare them mentally. And we tried to avoid communicating in large groups or all at once. We broke it down into departments so that it could be more specific. And we had to be clear and explain the rationale for doing certain things, like split team arrangements and different workflow processes that had to be put in place. And of course, we had to manage the emotions because this was a large change and very sudden, and things in the early stages, things were changing very rapidly. Every day a new advisory would come out, and it can get very confusing. So we had to manage the emotions and to prepare the staff on what was coming. So back on the PPEs and how we consolidated it. So because different levels of protections are needed for community and healthcare workers, we had to consolidate from all the different departments what was the level of protection that they needed for their staff. And we had to ensure that all our staff and volunteers know the proper procedure for donning and doffing all of these PPEs. They had to be used correctly and regularly. And we also emphasize on the need that just these PPE isn't enough. It has to be together with hand hygiene and with proper disposal methods. So we also have this link of resources from our national environment agencies on disinfectants. So our administrative department worked very hard to ensure that we had an existing stockpile of all these of chemicals that were viable for use, and to ensure that every site had their own stockpile and that there are people who know how to use these chemicals together with the PPE. So we had to implement several workflows, such as office responsibility, personal responsibility, cleaning of your own areas. Number two, things like contact tracing. What do we do if someone is coming into our office? What are the important information that we should take down of? If scenario A happens, what is the next step? If scenario B happens, what are the next steps? So on and so forth. So all of our staff had to be briefed on this workflow so that they know, so that everyone is on the same page, especially if the multiple advisories in the early days coming out constantly. Now, outward facing, or not within the staff internally, but more for our volunteers, we conducted training sessions. The first training session was on basically information on COVID-19. We provided them information on as up to date as possible during that moment of training, information on the pathogen, for them to understand the different modes of transmission and the incubation period, signs and symptoms, for them to be on the lookout for vulnerable communities, and how they can protect themselves for home-based care. Home-based care, not just for COVID-19, but also for your common cold, so on and so forth, such as things like disinfecting touch points, doorknobs, having a bin with a lid, and ensuring that they wash their hands and things like that. We also briefed them we also had a session on epidemiological concepts because most of them don't really have a background in it. So we just wanted them to understand what was happening and how they can parse all this news and what it means to them as a volunteer. So we covered basic concepts like reproduction number and very commonly in the media, what they've been hearing, flattening the curve. Also on personal safety and mental well-being. Personal safety being things like the proper cough and sneeze etiquette, coughing and sneezing into your elbow, the proper steps of hand washing, so on and so forth. Now, the second training that we did was on emotional and mental well-being. This was to give them knowledge on the stress responses during a pandemic, and the stressors that they may encounter as the public and as volunteers or first responders. We also provided them with self-care tips and practical self-protection measures. The other two sessions were conducted by Samuel, which was lessons learned from China and business continuity planning. This was not only for our volunteers, but also for our partner organizations in the region. And we highly encourage that if there's a capacity, volunteers should train or should pass on this knowledge to their local residents, to their friends and family to take over, just so that we can reduce the manpower strain and give the communities a sense of control. In the meantime, while all of this was happening, we also had our HR and IT departments prepare for the possibility of working from home, which is the current situation right now, where most of our staff are working from home. Human resources, they had to ensure that insurance is covered for staff and volunteers, that split team arrangements prior to the whole, to our entire office working from home. We were conducting split team arrangements where team A would be in office, team B would be at home, and we would switch every couple of days or week. And then, so there would be travel and stay home policies. When can they return to office, and what are the procedures if they want to return to office, lunch policy, so on and so forth. And from the IT department, they had to ensure that there were sufficient laptops, office phones, and that our lines remain connected even if we are working from home. Yep. So with all that in place, that we could then focus on our essential services and implement new services. Prior to the circuit breaker measures, i.e. Semi-lockdown in Singapore, we had a reading and tuition program for children and youth. So once this happened, we adjusted the curriculum to include hygiene, care for self and others. And in our Red Cross Home for the Disabled, we implemented closer monitoring of residents, enhanced cleaning and disinfection of touch points at wards, and thorough and frequent cleaning and disinfection of common areas, common surfaces and premises. And we also had a constant shout out for blood donations and ensuring that additional precautionary measures were in place to protect the well-being of our blood donors. One of the future programs that we are planning to implement once this circuit breaker measures are lifted is the delivery of customized care packages for our elderly. These packages are based on the feedback from each elderly on what they need, be it food, medical supplies, the cleaning supplies, so on and so forth. On a more broader scale and within the region, our International Services Department was very much focused on medical supplies during the early days of this outbreak. So we worked with multiple partners, Singapore Airlines, Paramva, Nepal, the IFRC to obtain negative pressure ambulances, with One Foundation on community checkpoints, and World Vision for hospital equipment. But now that we have that pretty much settled, we've started working on back to school programs or programs for the community in China. So one of this is the provision of school community hygiene kits with World Vision. So these school community hygiene kits are kits which are provided to the school administrators so that they can keep the classrooms clean. And within that kit, there's also soap and hand sanitizers provided for the students to use regularly. With the China Foundation for Poverty Alleviation, we are working with hygiene education and provision of personal hygiene kits, first aid kits, and female sanitation products for the village school children, and also on livelihood assistance and agricultural support. And with One Foundation, we have a back to school project in the works, which is quite similar to all the other projects. Yep, and with that, I will hand my time over to my colleague Samuel, who will be talking more about lessons learned from China and from the region. Thank you.
Thank you very much, Nadia. So maybe I'll just share a bit on the East Asia and Southeast Asia region. But since the outbreak began in China, maybe we can do some sharing, focusing on the China's experience as well. So looking at this graph, we can see how the impact actually evolved. So looking at Hubei, the bright red where it started, and then it spread outwards. So if you look at the Guangdong and Jiangsu, that's where the ports are mainly located, and that's why we see a larger number at the border as well. Next slide, please. So maybe just to share this, and I think everyone is familiar with it already. according to China CDC, we are looking at 4 different scenarios. Number 1, with active intervention, containment strategy, overseas importation control strategy, and the mitigation strategy. So looking at the X and Y axis of time and cases, we can see that with no active intervention, the number of cases will sharply increase and then decrease because the number of people or the population decreases, of those who have already got those who already went through the recovery stage, assuming they will not get infected again. And of course, we look at overseas importation control strategy. We can see it's always a fluctuation, but as more borders are closed, we would see a more constant or a zero for that level. Another one would be the mitigation strategy. So if you look at mitigation strategy versus the containment strategy, we can see that mitigation strategy would have a higher peak, which means a higher number of cases, as well as a more prolonged period. So overall, if we look at the number of cases as well as the time, it seems like with containment strategy, it is still the best strategy forward, just to reaffirm that. Next slide, please. So looking at the China experience, although there are many key lessons, I'll just focus maybe on 4 for today. Happy to share more after this session. If you look at how the government and communities must work together, we can see that it needs both parties to cooperate with one another. So maybe next slide, on the government 4 earlies in prevention and containment. So in China, they have this mantra called the 4 earlies in terms of prevention and containment. They're early detection, early report, early quarantine, and early treatment. So I think this is quite familiar. Basically, at any residential community parks, roadblocks and whatnot, there's always temperature taking. If there's a suspected case or not, you have to report within a certain time, 2 hours and 2 hours. If it's positive, the test results must come within 12 hours. And if it's positive, of course, you will be sent immediately for treatment, as well as the tracing of close contacts, etc., etc. So that is kind of the situation or the 4 mantras that the Chinese government actually adopted and pass it on to all levels. Next slide, please. So if you look at self-responsibility, it's pretty much what we are familiar with, so I will not really go through. But I think I'll just highlight the fact that this is a global issue because we have never been exposed to the virus before and we have no immunity. And it's actually quite natural throughout history that viruses evolve and spread. And then it depends on us, to have the immunity and as well as vaccines or cure, etc. So basically the underlying point is there's really no shame or blame if people become sick or with the infection. Next slide, please. So maybe just to show how the government as well as the community interact with one another, I think we do see a huge success also attributing strongly towards the trust and compliance within the Chinese public, as well as how much or how fast people were able to mobilize volunteers on the ground. So that's the key point, I guess, in terms of the prevention and containment strategy. Oops, next slide, please. So in terms of medical treatment, which is more the health aspect of this, it would be the mantra of 4 concentration. So in the interest of time, I'll just go briefly. So basically what happened is China, as well as a lot of other countries, they actually did triaging where they separated COVID-19 and non-COVID-19 cases to prevent cross infection in hospitals, especially to healthcare workers, as well as general ward. So doing a study in Wuhan, they found that actually most of the hospital cross infection occurs in general wards when unsuspecting cases spread to others without them knowing. So having clear triage and separation helps. Second is the concentration of experts, around 60,000 medical doctors and healthcare professionals in Hubei province. Now we are seeing an increase in cases along the land borders of Russia, Cambodia, Myanmar, etc. So China is actually introducing like mobile medical teams to respond whenever there are cases. Concentration of resources to focus on the serious and critical patients, as well as the concentration of treatment. So it's definitely proven that the earlier you treat cases, the better it is. And there are also some cases where, you know, healthy and mild cases suddenly worsen for no reason, or maybe due to the reaction in their body. And that's why it's always important to start treatment as early as possible. And there goes to the point of early detection as well. Next slide. Next slide, please. So I think I just want to emphasize this, that there's actually a very huge intersection between the health as well as the wash elements. So although the key point or the key motivation for most is to reduce the number of ICU load, the load in the ICUs in hospitals, as well as there's a huge focus in hospitals. But it's also very important to know that there is a huge part within the community that must be focused on. So in the end, China focusing on reducing infection rate, reducing the mortality rate, and increasing recovery rate, which means that while we strengthen the capacity in hospitals, there is also the reduction, the need for more community involvement as well. Next slide, please. So moving on, just to share some examples from East Asia. So on the left is from Red Cross Society of China, and as you can see, the volunteers are now training the local residents after some time, so that, you know, you empower the communities as well. On the right, you can see that there is from the Korean Red Cross, where volunteers from the community-based wash programs actually introduce the use of drones, which are equally effective in disinfecting large public spaces, which can be contrasted to the use of disinfecting trucks as well. Next slide. So this is just some pictures to show the health aspect in East Asia. Next slide. So this is from Hong Kong Red Cross, the branch of Red Cross Society of China. So as you can see, this is the sharing of hygiene kits and some IC materials. But I think more importantly, you can see that the volunteers are face-to-face teaching the elderly on proper hand hygiene and hand washing procedures and proper hygiene methods. And that is quite critical. I think it drives the message that while there are directives that says that we should try to keep a distance with the beneficiaries, on the ground, it may be very hard if you just leave the care packages because this group of people may not know or may not understand. So sometimes interaction may be unavoidable on the ground. Next slide. So just to share some other examples to reinforce the point, on the left, Cambodian Red Cross, on the right, Lao Red Cross using the speakers. Next slide. Next slide, please. Similarly, we see on the left from Indonesia, and on the right, Vietnam Red Cross, where you can see that basins, temporary wash basins are developed so as to provide kind of wash programs as well for the community. So for Vietnam, for example, they are doing at banks, markets, etc. Basically, it's going to where the people are and having to explain in a way that they can understand. Yeah, maybe you can take this more in the Q&A part. Next slide. So I think in the next few slides, and Fauzia, if you could just go through the next few slides, you'll see some examples of reporting that national societies have done. This is by Indonesia. Next slide. Myanmar Red Cross. Next slide. This is by Korean Red Cross. Next slide. And the last one should be from the IFRC global kind of reporting template. I think there's some internet connection. But I think basically what I'm trying to emphasize is that in terms of reporting, it really depends on who your target audience are and what format you want. And depending on how much capacity you already have, like an IM manager or a PMER in-house, you can do different ways of presenting. But if you see maybe after this presentation, that the numbers and the ways of measurements are relatively the same and it's pretty simplistic. For example, the number of health kits as well as the maybe number of volunteer hours, because very specific numbers are very hard to capture during this period of dynamic flux. But I think in terms of monitoring, where you are capturing all the data, the experience that we have so far is that if you want people to voluntarily give you information, it's also very important to ask the question, why should they give you, and what are you providing them in return? So for example, in East Asia, we are doing this thing called the situation report in East Asia. So while the national societies provide information to us, we are also sharing the information of other national societies to them. And that's why there's this kind of sharing and collaboration going on. So it's about a two-way relationship, not just about asking information from the party. So I think in the interest of time, I will end here, but happy to take more questions. Thank you.
Thank you, Fauziya and Samuel, for a very comprehensive presentation showing how Red Cross Singapore was, implementing the actions in Singapore itself, but also in the other regions, and some of the lessons from China, I think is very useful for colleagues. In the interest of time, maybe I request colleagues to please put your questions in the chat box so that we take it later. And then now, we're very close to the time. So I would like to invite Louis Maudi, who is our Chief of WASH in Philippines, to please share with us her experiences so far in responding to the COVID-19. Over to you, Louis.
Okay, thanks, Anu. I'll share my screen. Can you hear me okay?
Yes, yes, please.
Okay, so thanks very much for inviting us. I certainly was a bit nervous when Anu asked us, because I'm not sure we're quite on top of everything that we should be doing here. But I'll share what we've done and what lessons we've already been learning from our response so far. So in the Philippines, the first case was detected and reported on the 30th of January 2020, and it was an imported case. And through February, there were 1 or 2 more imported cases detected until we reached around 6, around mid-February. But there wasn't really any local transmission until later in February and early March. So it was only in March that the government raised the COVID alert system. And on the 16th of March, they declared a state of calamity and expanded what they called enhanced community quarantine for all of the Luzon region, which is all of the northern part of the Philippines, including the capital city. So that happened quite suddenly, and it basically meant a full lockdown of everybody, so people not allowed to leave their homes, only essential care, like key workers like health workers allowed into the streets, and people allowed to leave their homes just to go shopping, and depending where you lived, it was more strictly implemented or not. But on the 24th of April, that enhanced community quarantine was extended until the 15th of May, but this time just for specific areas where there were higher caseloads. And that does include the National Capital Region, where UNICEF offices, the main office is based. And the rest of the country are subject to general community quarantine measures, which mean non-critical businesses can be open. There is a little bit more freedom of movement, but there is still control in terms of movement, and there are still curfews, and there's still some limitations on who can go where and do what, which obviously has implications for our work. So far in the country, we had, as of yesterday, just under 9,500 cases and 623 deaths. Our testing capacity is not really at full scale yet. They have been gradually training and certifying regional laboratories to be able to do the testing. And we see essentially so far a steady trend of between 200 and 300 cases a day. And that hasn't really changed much, even while we've been in enhanced community quarantine. So I'm not sure what that means for the 15th of May, if we will definitely come out of enhanced community quarantine into general community quarantine, or if they will decide to continue this enhanced quarantine in certain areas. So in terms of the UNICEF response, what we have been doing falls into kind of these three broad categories. We have been supporting the WASH cluster through coordination through online meetings. We've been working with the partners to develop a cluster response strategy and plan. That's part of the overall humanitarian country team plan. Through our work with Department of Education, we've also been coordinating the WASH in Schools Technical Working Group to see how we can look at children returning to schools safely. And for both Department of Health and Department of Education, we've been working on activities and budgets for new normal planning. So essentially all departments have been asked to review their 2020 budgets and see how they might reprioritize their activities for the rest of the year and reallocate budgets accordingly within their approved budget. So they haven't been given additional funding, but they've been asked to reprogram their funding based on what is now feasible to do and what is now most important to do. So we've been trying to help advocate with Department of Health and DepEd for those measures that we think are most critical. Under risk communication and community engagement, our immediate first step was just to repurpose the existing hand washing promotion materials that we had as part of our overall WASH materials. Both materials that we had developed with Department of Health as well as Department of Education and the Department of Social Welfare. And then we've worked with the comms team to develop new social media cards, videos, radio spots, and they're both for UNICEF specific use, but also working with Department of Health to develop their materials and their strategy. And we are now also planning a specific hand washing promotion campaign to be developed. In infection and prevention and control, we've been working, initially it was in support of the health colleagues and the Department of Health to develop general infection and prevention and control guidelines and training materials. And we then went on to develop more targeted guidelines and training materials that were more targeted at the sanitary workers that work in healthcare facilities, in community settings, in the newly established community quarantine centers, and so on. We've been procuring or trying to procure, and I'll come to that later, cleaning and disinfection kits. We are going to be doing household hygiene distribution kits, both from our regular kits, because we have those in stock, and we also will develop a modified kit once some of the community quarantine is lifted, because at the moment our suppliers are all locked down. We've been working with the health colleagues to also make sure that the WashFit indicators are included in the healthcare facility and community quarantine center reporting tools. And in-house, we've been looking at how to develop the ODK reporting tool to collect the WashFit indicators specifically, so that we can have a database that we can build on from there. We have been providing support for emergency wash facilities, for healthcare facilities, community quarantine centers, but also within BARM, we've been setting them up in, oh, can you still see my screen and my presentation?
Yes, Louise.
Okay, sorry, for some reason I can't.
You can see the slide on the 3 pillars.
Okay, I'm not quite sure what's happened. Just a second. Okay, sorry. Not sure what happened there. But also within some areas where they have security checkpoints and control points at the entrance and exits to certain communities, because they're under even stricter lockdown measures because of the number of cases within those communities, also setting up emergent temporary hand washing facilities at those points. And then we have also been supporting and will be supporting additional washing schools training rollout. So just some kind of broad points. In terms of WASH coordination, just in the context of the Philippines, WASH is a subcluster under the health quad cluster. So there's health, nutrition, WASH, and mental health and psychosocial support are the 4 subclusters under the health quad cluster. Initially, though, although an emergency response was declared, a state of emergency was declared, a different mechanism was established for coordinating the response. And that was based around the pandemic preparedness that the Department of Health had done with the World Health Organization. So that didn't really engage the subclusters under health and really treated it as a medical health emergency initially. So we had to engage, we were able to engage through our health colleagues to make sure that WASH was being included as part of infection and prevention and control. But we struggled at the beginning to get WASH to be seen as a substantive part of the response. Without the Department of Health, because they just didn't have the time, even though they're meant to lead the WASH cluster, we went ahead with having online coordination meetings with the WASH Strategic Advisory Group members to discuss what our response options were, particularly considering once the lockdown period started and how we may be able to respond as we gradually gained access to different areas. And as I mentioned earlier, we developed the WASH chapter of the HAC. One challenge we had is that I'm sure it may have been the same in other countries, but we seem to always receive it on a Sunday morning with a request for it to be returned by Sunday evening. So it was sometimes difficult to engage with the partners on that. So we had to use what we had discussed within our the WASH-SAG coordination meetings as our basis for developing the strategy and the plan and the information that we had on what partners were planning to do. And we weren't able to get feedback from the Department of Health as we developed those chapters because of that timing issue. So in terms of WASH partnerships, in fact, we were not able to activate. We have a number of standby humanitarian partnership arrangements where the documents are already prepared, pre-reviewed by our partnership review committee and ready to sign. But all of our NGO partners were also under lockdown and experiencing restricted access to the key implementation sites. So there was no point really in activating those standby arrangements. Instead, what we were able to do jointly with the health team was repurpose some existing partnerships that we had ongoing for polio response. So with the Philippines Red Cross and with the Health Organization of Mindanao, and both of those, just because of the nature of those organizations and their relationship with the government, have more freedom of movement, and because they have this network of volunteers more at the community level, even if they are under lockdown, they're still able to operate within those communities to some extent. So with those partners, we're able to look at doing infection prevention and control training, do hygiene promotion and other risk communication and community engagement outreach activities. They'll be doing, HOM have started, and Red Cross will begin soon to do distribution of cleaning and disinfection kits and family hygiene kits in some of the most, in the poorest communities within the metro area where there are high COVID caseloads. And then we have, through them, begun installation of hand washing facilities, both drinking water points and water for hygiene water points, and emergency and temporary toilet facilities at healthcare facilities and community quarantine centres that need it. So as part of the risk communication and IPC measures, we've worked both internally to have UNICEF branded materials and outreach, and we've worked with the Department of Health. But all of the work that we've been able to do so far has been through social media, television, radio, and those kind of channels. Because of the lockdown and the restricted movement measures, we haven't really been able to do any of the usual kind of community-based, face-to-face C4D activities that we might normally do in a humanitarian situation. So under the Department of Health lead, we supported the development of risk communication plans and materials. And we've worked then with UNICEF Health, the World Health Organization, and USAID to develop these infection prevention and control guidelines and materials. As I mentioned, we have the general one, and so far we've reached over 2,500 people. That's jointly conducted with the health team. And then the cleaning and disinfection TOT we just launched last week. And so far we've reached 286 people. And our target audience for that is the regional and provincial and municipal sanitary engineers and sanitary inspectors. And the aim is for them to then be able to guide the cleaners and sanitary workers that are doing cleaning and disinfection and solid waste management at the healthcare facility and community quarantine center level. Some of the challenges we've faced under this is that there's been an internal coordination issues within the Department of Health. So different departments were issuing guidance. So the health promotion team was working with one set of stakeholders, and they would come up with guidance, including on infection prevention and control, while at the same time the environmental health team would separately issue their own guidance, and often they weren't matching. And so what that has been a challenge. There were also multiple teams who were not talking to each other that developed different communication plans and sets of materials. And so it took a little while to bring those different groups within the Department of Health together, and the development partners that had been supporting those different groups together to support them in a more holistic way. And I think the fact that the health quad cluster wasn't formally activated and this separate pandemic coordination structure was implemented was part of the reason that we had some of these challenges. Another challenge has been how we keep the issuances up to date. So obviously we're learning all the time more about the virus. We're getting updates from headquarters, from WHO around what to do for COVID, infection prevention and control. And I think Department of Health has felt slightly frustrated by this, that one day they issue a guidance note and disseminate it, and then maybe 2 days later there's an update from headquarters, and they've come under criticism from the political level of government for seemingly flip-flopping sometimes on on guidance. So one example was guidance that was issued by the environmental health team on spraying for disinfection. And then a couple of days later, we got the WHO global guidance, which recommended against misting of people as part of infection and prevention and control measures, as well as against large-scale environmental spraying. So then, you know, I think the Department of Health then, a different section of Department of Health then issued guidance that was updated based on the global guidance, and this led to friction within Department of Health and friction between the Department of Health and the political level, who felt that the Department of Health were showing insufficient leadership. So obviously there's fallout, potential fallout there. So these are just some of the examples. As I mentioned, we haven't got the option of face-to-face, so a lot of the materials we've been developing are for use on social media. We've developed videos showing hand washing. We've engaged celebrity ambassadors to promote hand washing. We've also been actively looking for opportunities for interviews. So we've been, the health and WASH colleagues have been on various radio shows, television shows, talking about COVID prevention measures and so on. And as I said, we've been doing these trainings. So these are some examples of photos sent by participants to us of themselves watching the infection and prevention and control trainings. It's created an opportunity for us. So in relation to our work with education, in the new Bangsamoro Autonomous Region of Muslim Mindanao, which has its own government, we were able to get them to fast track the adoption of their own WINS policy. And that they have based that on the national policy and standards, which is great. And that will enable us now to push forward with some of the other planned works related to scaling up of WASH in schools in Barm. At the national level, under the Department of Education, we've been supporting briefing webinars for DepEd teams at different levels, as well as supporting a review of WASH facility design. So the facility bureau is looking at how to adapt their current WASH facility designs so that they would ensure physical distancing during group hand washing, and also potentially minimizing hand contact with taps and things like that. So looking at different options there. One of the challenges is that the DepEd central office takes a very in a way, a little bit of a narrow view of what a WASH facility can look like. So they're not so keen on the low-cost tippy-tap kind of designs or the punch pipe hand washing facility. So we're doing our best to kind of advocate for those as options, and looking at how they can meet the minimum standards that the DepEd wants to have, while still being affordable for the schools to implement. The WINS Technical Working Group had been working on a WASH in Schools online course with Simeo Innotek, which is based here in the Philippines. And so that is now being, that will be run again, and we're pushing for more people to take it while the teachers are at home and not at school. And we're also preparing WINS-specific Zoom orientation webinars for some areas of the country which are a little bit further behind in terms of WINS implementation. And then we're working jointly with the WASH in Schools Technical Working Group to develop the Safe Returns to Schools guidance and IPC protocols. So one challenge under this area was that there are different coordination platforms with different members that work with the Department of Education. So obviously there's a development partner group, but there's also the WASH education cluster, the education cluster for humanitarian response, and then the WINS technical working group. So initially, both of those groups were working in parallel, but we've managed to bring their work together now, as well as, and through that, we've been able to also try to overcome some of the internal communication gaps between the different DEPED bureaus. In terms of supplies, to be honest, we were a little bit blasé at the beginning of the emergency. We thought we were well prepared if we needed to respond, because we have existing LTAs with suppliers in place for most wash emergency stocks that we would need. However, because of the lockdown, it has meant that all of our LTA suppliers, which are all based in the National Capital Region, are shuttered and so are not able to operate. So although we are able to mobilize some existing contingency stocks that we had in our warehouse, including family hygiene kits, it meant that for the additional supplies that we needed for cleaning and disinfection, we weren't able to get them through our LTA suppliers. And we've had to then spend quite a significant amount of time, a couple of months in fact, trying to source local suppliers that can pull together the kit or parts of the kit and provide those to us. And so that means that we will only get the first delivery of the cleaning and disinfection kits by the end of next week, I think, or by around the 15th of May. So that's taken much longer than we would have wanted, and has been a lesson for us, I think, in terms of maybe looking at how quickly we react to the situation. You know, look, with hindsight, we should have reacted more quickly. We're also developing a modified hygiene kit. So the current family hygiene and dignity kit is quite expensive, but it is designed for a family that has been displaced. So there are some items in there that we can remove for families that are in their home setting, and then we will add some additional cleaning and disinfection materials, and it will end up with a lower total cost. And so we've already started preparing to do the procurement for that once the ECQ is lifted, because we do expect to see, as other countries have, some surge in cases when the enhanced community quarantine is lifted, particularly in some of the congested and poorer urban areas. So with hindsight, I think we feel that we should have pushed much harder for the overall health cluster to be formally activated by the Department of Health, including within that the WASH subcluster, and for that to be part of the new coordination structures that were specifically set up for COVID-19. So there is a Department of Health Emergency Operations Center, there's an interagency task force on emergency and infectious diseases, but they operate separately to the cluster system. And so that's why at the beginning, a lot was going on within the Department of Health and the government that none of the development and humanitarian partners were really kept informed of or aware of. And so that meant delays in us taking action, and also delays in or gaps in how the response was initially framed, as I said, more as a health emergency compared to a more holistic response that's needed. We also were engaging more with the technical level, and we should have probably raised it up to more senior management within our office to take it to the senior level of the health department earlier than we did. So we did eventually do that, but we probably should have done that sooner. In terms of contingency planning, as I said, we felt quite relaxed that we were prepared and ready for an emergency response, but none of our contingency plans took into account the extraordinary situation that we find ourselves in at the moment, in that we're all locked in our houses, and so can only interact with both our NGO partners, our government partners, the sub-national level where we have programming. We can only interact with them by phone or by these web meetings. We should have also started, as I mentioned, procurement of the cleaning and disinfection kits earlier. And although there was no local transmission reported during the first weeks by the Department of Health, I think we should have taken a no regrets policy and started to procure those earlier than we did. And if we had done that, we would have been able to procure before the lockdown started. And I think another lesson that we've learned is that we need to have LTAs with suppliers that are based in different parts of the country. So we have tried in the past to find suppliers outside of the National Capital Region, and where we have found them, they tend to be relying on manufacturers that are based in the National Capital Region. So we haven't pursued that, but I think we need to look at it again and see how they can potentially have a minimum guaranteed stock at subnational levels in different areas, because as we've seen in this emergency, once the NCR is locked down, or if it's affected in the future by a big earthquake, which we are anticipating, then we basically are paralyzed in terms of supplies. So moving forward and looking at how we think we'll return to a new normal. So we've been reviewing our 2020 and 2021 rolling work plan, and we've deprioritized or identified a number of activities that can't be implemented in 2020. So we were planning to have a WASH country program evaluation this year, but that won't push through because the government stakeholders that we need to involve will not see this as a priority at this stage. We were also planning to try to implement a WASH BAT at national and at the level of BARM. And again, because of the COVID priorities, we feel that the stakeholders won't have any space. And also the methodology that we would normally use for WASH BAT, we don't feel that it'll be likely that we'll be able to convene workshops and different stakeholders to conduct those exercises. We had planned to do research on the impact of an M8 menstrual hygiene management package that we've developed this year, but because the school year is going to be completely disrupted, it will start later than planned. There will be an adjusted learning schedule to allow for physical distancing and so on. We feel that it's not feasible for it to go ahead. We will be looking at how the MHM package can be adapted for this new context, but we will wait and do the impact research at a different time. We also decided that the strategic human resource development plan that we were going to develop in support of the Philippines water supply and sanitation master plan rollout will have to be put on hold. The master plan itself has still not been launched, so it was almost going to be launched just before this all started, and it's been kind of put on the back burner, even though our position with the government is that master plan itself can be part of contributing to COVID recovery. They are not seeing it that way, so they're not prioritizing having it signed off by the president and launched. We had also planned to do sustainability monitoring in areas that we worked on under our previous country program to see how well the open defecation free was being sustained, to see if the governance structures that had been put in place are still working. But again, looking at the feasibility of freedom of movement, wanting to limit exposure of staff and partners to potential infection, we're going to cut that out. And we had also been planning to test and model different septic and fecal sludge management options as part of moving towards SDG 6, safely managed sanitation. But it's not that we don't think that's important, it's just that then when, as we'll see when we go to the next slide, when we look at all the additional things that we now need to do, we feel that that's less of a priority. So the opportunities we have are that we really want to have a much stronger push on our advocacy for WASH and our technical assistance to strengthen WASH planning and budgeting as part of this new normal planning that the different departments are doing, and that will be done also at the local level. We're partway through developing WASH in emergencies national policy and technical standards, so we want to fast track finalizing and having that approved and rolled out. We also, under the lead of the World Health Organization, have been supporting the development of national guidelines and standards for WASH in healthcare facilities. So we want to see how we can fast track that this year. And as part of the emergency response, we're developing this ODK, WASH in healthcare facility monitoring mechanism, which we hope can then serve as a basis for a longer term monitoring mechanism. And for WASH in schools, those of you who attended the WASH in Schools Learning Exchange last year know that WASH in Schools is fairly advanced in the Philippines, but one area that we will be working on is DEPED has identified a number of what they're calling last mile schools, which are the schools in very remote, isolated rural areas that have very poor facilities, struggle to attract teachers and so on. And so they have they have quite an intensive plan to improve those facilities and improve the overall learning conditions and so on. And so we're making sure that WASH is part of that. And now that the BARM, now that the BARM policy has been approved, we'll also be strengthening and pushing the rollout of WASH in BARM.
Hi, Luis. I know that you're towards the close of the presentation, so.
Sorry, this is a final slide. Sorry.
Right, in 1 minute. Yeah, we really over time. Sorry for that.
Sorry about that. Yeah, so the final slide. So then the other additional opportunities is there had been a plan to develop a model for municipal run water utilities, which would then kind of adopt all the community level water systems and take over management of those. So we can look at that. We're also looking at strengthening engagement with the private sector through an alliance with other partners, and we can use this as a way to push forward the Wash for Work agenda. As I mentioned, we'll have the national hand washing campaign. And then bearing in mind, we have the upcoming typhoon season, we also need to relook at our contingency planning and preparedness for that, considering the potential limitations on movement around the country. Okay, thank you very much. My apologies for running longer than planned.
Well, thank you, Luis. Thank you very much for really sharing a very, very comprehensive experience from Philippines, and not only talking about fighting the COVID-19 problem, but also thinking more longer term in terms of recovery and planning for the future as well. So I see that there are not many questions. I just saw there was one question from Mukhtar on how are you responding to the Mindanao region, and I think you have covered very well in your presentation. You know, because we also have lost some of our participants. Maybe before we close, I would like to invite quickly Kelly, if you have a few words that you want to share from the global level.
Great. Can you hear me okay?
Yes, very clear.
Yeah, great. Yeah, hello, good evening, everybody. So, or good morning, actually, on your side. Oh, this has been a really excellent presentation. And I just think, we're every day here, I mean, kind of running through, we have over 140 countries right now that are responding to the COVID emergency. And just, when we can see just the comprehensive and, very thoughtful response in one country, it just helps us really understand the scale of what UNICEF is doing to bring WASH services, up and running in such a comprehensive way under such a challenging circumstances. So I think, EPRO was the region that was really kind of first off the starting line on this response. And I think, this whole course, we've been learning a lot from what's been happening in the region and kind of integrating that and kind of growing it on the global scale. So, we really appreciate just the contribution that the countries in the region and the regional office have made to really, kind of a formative role in the response. I think just one point that I just wanted to make, and I think just for you to know, is that we are very aware of some of the challenges that have happened, especially with the way that the architecture of the response has happened with the strategic preparedness and response plans. And, it is something that we're taking up at the highest levels with WHO and trying to look at this issue of articulation with the humanitarian system and the cluster. So it is quite complex, and myself coming from the field, it seems much simpler than it is when you look at these things in the global spaces. But I think we're making some really concrete progress, and we hope that the forthcoming plans that WHO will be putting out for the country response will have WASH in a much better position. But yeah, just really huge congratulations, and we really appreciate all the great documentation and stories and experiences and lessons learned that are coming out, and look forward to continue working together closely as one WASH team through the COVID crisis. So thank you very much. Back over to you, Anu.
Thank you, Kelly. Everest, maybe I hand over to you now to close the session.
No, thanks very much, colleague. Thank you, Dr. Chris. Maybe Dr. Chris left already. Thank you also, Louise, and then thank you, our colleague from Red Cross in Singapore, IFSC for Singapore. Thank you, Simon, to be there, and also Louise for a very nice presentation as well. I think this is only a part of the series that you have started, and then we will continue as we move on to have one every 2 weeks. One of the things that we agree on during the regional WASH coordination meeting is not only have UNICEF as such, but have all the partners to come in to present and then discuss what are the issues, what are the challenges that the response is facing. One of the key I think that we agree on is to have some thematic area in the coming weeks where we can have more discussion, more focused discussion related to that as well. And then have a lot of country cases to plug into to make it more comprehensive and more operational. So I would like to thank you very much to be part of this webinar series. And we will continue to give you more information. Anu and myself and our colleague of ACF, Action contre la faim, will be on the edge basically to provide you most updated information on our webinar series, our information, and the platform on which all those information will be shared as well. Thank you to be part of the discussion, and then have a very nice day.
Thank you, and our apologies for the time, but thank you for your very valuable time. Thank you, everyone. Have a good day.
Bye-bye. Bye.
Thank you. Bye.
Bye-bye.